Hi, everyone. We're having some technical difficulties. I apologize. I'm not sure if you can hear us, but we're trying to work through it, so just give us a moment. Can you see us? Perfect. Okay, great. All right, well, welcome to our first webinar for our virtual state HIT day. Normally we have this day actually in Sacramento when we go advocate in person, but obviously given the COVID response, everything's become virtual. This event is actually going to combine 3 webinars in May with a virtual march at the Capitol to support California telehealth legislation, and the march will launch today and last until May 30th. So here we would like to also thank our advocacy team, which consists of Nancy Hall, Dr. Lerer Ozeron, Reggie Tue, Esther Tolino, and Ian Slade. In addition to that, we are privileged to have some national advocacy speakers with us. First of all, I'd like to present Alana Lerer.
Thank you very much. It's a pleasure to be here with you all, presenting on behalf of the HIMSS Government Relations team. And I also am joined by my 2 colleagues in HIMSS Government Relations, which I will introduce afterwards. Again, I'm Alana Lerer. I'm Manager of Government Relations for HIMSS. And Jenny, I don't know if you're showing the slides. Yeah, there you go. All right. So I will focus on first Advocacy 101. And then and how to participate in the exciting virtual march that's launching for your chapters today. And then go into how the federal and state governments are responding to COVID-19. Next slide. All right, so we'll start with a briefer on advocacy, whether it's virtual or in traditional in-person settings. So these are some important points that I wanted to start off with. Chapters, HIMSS believes that chapters are the grassroots arm of HIMSS and have immense power to advocate for public policy relevant to health IT priorities, particularly at the state and local level, where you can be the voice on the ground and form relationships with legislators and administrators at the public level. Anyone can be an advocate. If you have the passion and the drive, you can advocate. So you can forget the notion that you have to be a high-powered lobbyist to advocate. And finally, advocacy is a year-round effort. It, of course, involves Advocacy Day like this one, but engaging public policy stakeholders at other meetings and events throughout the year and building and sustaining relationship is key for any chapter to influence public policy. It's a lot about relationships and sustaining those. Next slide. So these are I'll show you the do's and don'ts of advocacy meetings. And although we're not meeting in person with the legislators and the legislative offices, it's still good to understand these for, you might be virtually meeting with legislators or at another time, or you might be, have these tips in your pocket for next year, of course. So it's important to make an appointment in advance. They have busy schedules, and it's an important point to keep in mind that it's their job to see constituents like you, and they enjoy that. But obviously their schedules are packed, so at least 3 weeks in advance, it's good to make an appointment. Research and prepare is very important with your other members that you're joined by on your legislative visits. It's important to research your issues, whether they be interoperability or telehealth, and to also research the official or the legislative staff member that you are meeting with. They may or may not know health IT or healthcare jargon, so it's just important to see if the legislator approved bills in the past or not at all. And thirdly, it's the key to advocacy is focusing on including data, both data and local stories. That will bring you a winning argument. If you say, for example, telehealth brought 70% of patients were satisfied by telehealth in this San Francisco facility. But also I was caring for my elderly mother who used telehealth, and she was satisfied as well. That's just an example of how you can combine data and stories to make a winning argument. Next, you want to use clear, succinct language to get your point across. You might have just 15 to 30 minutes to meet with them. So just be clear, concise, and direct, and know that you, for that meeting, are the authority on the issue and probably know more about the issue than the staff or legislator. And then finally, follow up and cultivate the relationship. Next slide. So these are some things to keep in mind to avoid doing. First is engaging in partisan politics. No matter what side of the aisle you're on and the legislator is on, you can always find middle ground. And fortunately, health IT is not, it's usually bipartisan. You want to avoid negativity, leave any preconceived notions aside, and just remain courteous and factual. Don't be late, and just be aware of lines at the Capitol that you want to just leave a little earlier than you think you might want to, and and then you'll have time to plan your pitch one last time. And like I said, try to avoid using jargon unless you know they're more familiar with health IT if they've passed health IT legislation in the past. And don't leave your house empty-handed. If you can give staff folders, info sheets, and business cards so they can easily remember you and go back to a resource afterwards. Next slide. So this is a little bit about how you can set up and outline your meeting with the legislator or legislative staff. So setting the stage, giving the punchline, and giving the closer. In setting the stage, you want to say who you are and who you represent, especially if you are a constituent of the legislator. They like to hear that. And about HIMSS, and that HIMSS represents a diverse membership. And this is beneficial to officials because HIMSS has already done the collaborative work of gathering different voices at the table, which is different from some other organizations. The punchline, what are the issues? Why should they care? Again, including data and stories. And finally, the closer, what are you asking for? What are you leading up to as the asks? Or how can you be a resource for them in the future? Maybe you can research health IT issues for them. Just make sure that they know you can be a resource for them in the future. Next slide. All right, this comes down to your virtual march, which your chapter leaders are proud to present today to the Northern and Southern California chapters. And I'll say a little bit about the asks, and then I'll go into how to actually participate. So this is a little snippet from the virtual march, and I'll read it out to you for some context. Amidst the COVID-19 pandemic, California's advancements in telehealth adoption has become vital in coping with the increasing demand for healthcare access. As our state continues to face this public health crisis, we need your support to continue this expansion of telehealth throughout our state. And the bills that we are advocating for today and this month are the following. Assembly Bill 2164, which creates an e-consult service and telehealth assistance grant program for health center controlled networks, health centers, and rural health centers. Assembly Bill 2464, which establishes a grant program to fund a statewide pediatric behavioral telehealth network. And Senate Bill 1278, which ensures that generally accepted standards of practice that apply to a healthcare provider under their license also apply while providing telehealth services. So these bills clearly focus on telehealth during COVID-19, something that should resonate with legislators, since that's one of their focus areas right now. And I'll tell you a little bit soon about how states are acting on telehealth. The next slide. All right, so this is where you can, if you like, you can get out your phones and scan the QR code through your smartphone camera, or the chapters will send out a link as well shortly. You first, when you get to the site, you can fill out your personal information, which will tell the system to just identify your legislators based on your address. Then you click next, and you'll see the next page where we have a pre-written letter for you and the list of your legislators. And you are welcome to add to the letter. Again, stories are important, whether it's virtual or in-person setting. So you're welcome to add your own stories on what telehealth means to you, your family, your patients, etc. And then that's it, you're done. You click submit, and it takes a minute to complete. You'll see a message saying that there's an example social media post to, so we recommend that you share with your colleagues to encourage them to write to their legislators as well. I'll stop here for a minute or two to see if there are any questions in the box. Feel free to ask any questions in the chat box or the question box. All right, I don't see any questions right now, but we will have time later to answer some questions. All right, well, in the interest of time, I'd like to present on when should this be completed by is one question. Actually, that's a good question. It starts, the virtual March starts today, but it is able to be completed by the end of the month. All right, so I'll get into the federal and state policy response to COVID-19 relating to health IT. Next slide. All right, do you hear me? Okay, so congressional action to COVID. These are some of the congressional acts that have passed due to the public health emergency. And I want to focus on COVID number 3, which is the Coronavirus Aid, Relief, and Economic Security Act, or the CARES Act. This was signed into law on March 27th, and it's the largest emergency act passed by Congress so far. It's over $2 trillion relief package focused on healthcare delivery, state and local funding, business and nonprofit relief, and overall economic stimulus. And then we have COVID 3.5/4, which is the Paycheck Protection Program and Healthcare Enhancement Act, which was signed into law on April 24th, 2020. Next slide. So like I said, the CARES Act is the third and biggest coronavirus relief package signed into law. And these are the 5 key funding provisions that they're overall are included in the CARES Act. $377 billion goes to small businesses, including the Paycheck Protection Program. $500 billion is going to big business and at-risk industries. $600 billion is going to direct aid to help individuals and families. $340 billion is going to state and local governments, and $180 billion is going to health and other public services. Next slide. And these are some of the key healthcare, health IT, and funding provisions that I want to share with you. And if you're interested in learning more, we have a news article on this topic that lists all the healthcare and health IT provisions at the bottom of the slide. The first one I'd like to point out is about the CDC Public Health Data Modernization Funding. This authorizes $500 million for public health data surveillance and infrastructure modernization efforts at the CDC, state and local health departments. And HIMSS believes that this is critically important for public health. The public health infrastructure is unfortunately still in the 20th century, and there's a critical need, especially in the face of a pandemic, to modernize it so data can be shared easily, quickly, and securely. Second is Public Health and Social Services Emergency Fund, which provides $100 billion for our health system to respond to coronavirus. Coronavirus Relief Fund, which provides $150 billion to states, territories, and tribal governments. HRSA grants, which reauthorizes the grant programs that promotes the use of telehealth. There are several Medicare telehealth flexibilities due to COVID and stay-at-home measures, so one of them is removing the requirement that a provider must have treated the patient in the past 3 years. The telehealth distance sites are more flexible now. The CARES Act allows FQHCs and rural health clinics to serve as a distance sites where providers are sitting for telehealth services. And for the FCC, it provides the FCC $200 million to support telehealth efforts. Next slide. So the Congress gave HHS all this new authority, but what does it really all mean? Well, I'll tell you a little bit about what this means for telehealth, because that's a big policy change category. CMS relaxed a lot of requirements in response to COVID-19 for Medicare. They're listed on this slide, but I'll touch on just a few in the interest of time. And these are focused on only on the duration of the public health emergency. So there's a lot of emerging questions at the state and federal level on what to do after the declaration ends. Should we keep these policies or go back to what we had previously? So a few are the geographic limitations are waived. The originating site restrictions are waived. So any healthcare facility and patient's home are now eligible originating sites where the patient sits during telehealth. Providers can serve both new and established patients. And in the interest of time, I'll move on, but you can learn more about these changes at the links at the bottom of the slide. Next slide. Additional HHS waivers. The Office of Inspector General notified physicians that they will not be subject to administrative sanctions for reducing or waiving any cost-sharing obligations that federal program beneficiaries may owe for services. And the Office of Civil Rights, the OCR and HIPAA requirements is a major one. OCR will exercise enforcement discretion and waive penalties for HIPAA violations against providers that use platforms that were not allowed before because of HIPAA, and such platforms that are allowed now temporarily include Skype and FaceTime for telehealth. So this enables telehealth to be more accessible. And state telehealth licensure requirements, Medicare, in general, a provider must be licensed in the state where the patient is located. Now, providers can practice across state lines for Medicare. Next slide. So I will transition now to state level activity in response to COVID-19. The general buckets of actions taken by states include telehealth, which is usually defined as live video and voice, contact tracing and data surveillance, electronic case reporting, and health information exchanges, and states public health departments working with their health information exchanges. Next slide. For the purposes of this presentation, I'll focus on state telehealth changes. And what we found is that the majority of changes fall into these three categories: licensure requirements, Medicaid coverage, and commercial insurance coverage. So there were many, many changes under these three categories for states. Next slide. So before the emergency declaration, 49 states and DC require that providers delivering telehealth must be licensed in the state where the patient is located. However, states have individually taken action on this, and 49 states and DC are temporarily waiving licensing requirements for telehealth. Those states are shown in green. And this policy includes one or more of the following. Providers can practice across state lines, and the process is expedited to provide temporary licenses to qualified medical professionals. This is critical because it expands the workforce when there is dire need for more providers working, and also it expands access to care. Next slide. In terms of Medicaid telehealth policy changes, you'll see that all 50 states and DC have, in some shape or form, temporarily expanded access to telehealth for Medicaid recipients, and that's, of course, only temporary. So these changes may include, depending on the state, that the patient can be at home during a telehealth visit. There's payment parity between in-person and virtual, so their providers are getting reimbursed at the same rate. The state has added additional covered services for telehealth, and the state has allowed telephone without video, which is important for communities who do not have access to a video or good broadband, and removing requirement of in-person initial appointment. Next slide. So lastly, this is another big telehealth policy change bucket, the commercial insurer telehealth policy changes. Before the emergency, 40 states and DC governed commercial insurers, and other states can still create guidances for telehealth services, but only 6 states before allowed telehealth reimbursement to be equal to that of an in-person visit. During the declared emergency, you'll see the states in pink, 32 states are increasing access to telehealth, either on their own or through a government mandate. And some of these changes relate to the similar changes that Medicaid is covering, like patients can be at their home during a telehealth visit, etc. Next slide. Now, how has California responded in terms of telehealth? Medi-Cal, California's Medicaid program, and commercial insurers are covering additional telehealth services during the public health emergency. And out-of-state providers can deliver telehealth to Medi-Cal beneficiaries. Something else that's interesting that I haven't seen in other states is an executive order by the governor on privacy and security. And this executive order suspends a requirement that patient must give verbal or written consent for telehealth. It states it suspends penalties for inadvertent, unauthorized access or disclosure of health information during telehealth, and that services should be consistent with what I mentioned before, Office of Civil Rights Notice of Enforcement Discretion for telehealth. So that's important to note. And these are some resources that HIMSS has put together for you and other HIMSS members to take a look at. Their federal and state policy news articles, and they're on the CARES Act, telehealth, remote patient monitoring, which is interesting because a lot of states I haven't seen a lot of remote patient monitoring actions at the state level. Anyway, these are some resources, and now I'd like to introduce my colleague, Valerie Rogers, Director, Government Relations of HIMSS. Thank you.
Good afternoon, everyone. Can you hear me? I hope so.
Yes.
Great. So let's go to the next slide. We're going to talk about some immediate state and local strategies, a lot of which really mirrors what's already been happening, as Alana has shared with us earlier. What I would really like to just emphasize with this particular slide is that what we see by the federal, state, community level resources and response really sort of shifts to our home and community-based services. I think Alana alluded to some of the waivers that are now available for states. What is really important to convey here is that in California, leveraging some of these resources, these waivers, is really eliminating barriers to addressing the COVID-19 pandemic in California. And that's what's really great. I think some of the strategies that I will present to you that may obviously address COVID-19 right here, right now, but also future emerging infectious diseases or outbreaks that we may encounter among other chronic conditions that we can leverage the infrastructure, the groundwork that's being laid now. What is also really, I think, interesting here is that under the temporary waivers, one of the things that I thought was interesting is that now for Medicaid or Medi-Cal in California is that it will also pay or cover for phone visits. So for those of you who have parents like mine who don't want to let go of their flip phone, this is certainly kind of a relief, and it's particularly important for those who don't have smartphones or who don't have internet access at home. Another thing that really stood out to me in terms of what's already been done is the opportunities to expand opportunities for our FQHCs to leverage telehealth and reach patients in their homes. And that's something that was not available. You'll see on the bottom of this particular slide additional details that I think you'll find really useful. But for the sake of time, let's go to the next slide. I want to sort of talk about, I think, sort of a 3, maybe 4-pronged opportunities. The first is testing. Well, obviously, testing isn't, the foremost health IT related topic, but it is related. There are lots of connections. And there are some things that I didn't want to just leave uncovered as they have bubbled up during lots of conversations with you, our chapter advocates, and other members. And sort of 3 areas here that I want to emphasize, really 4. Number 1, expanding testing capacity across states and population centers. I talked about immediate strategy. This has to be an immediate strategy. Under the first bullet here, really want to emphasize healthcare workers, first responders, making sure those who are our providers, our first line of defense and response are well taken care of. I think in the quadruple aim, the 4th aim is to ensure that our healthcare providers are taken care of. And this particular focus is certainly, operative number 1. More so, strengthening public and private collaborations. We're seeing a lot more public-private organizations coming together, particularly around helping to expand opportunities for community-based testing, cost sharing, which is a big one, creating cooperative purchasing and distributions for test kits or tests. We've seen that in a few states now. That's really important to emphasize. And then I would say more so as we look at the standardization across different types of testing. So these are three really critical points that I didn't want to be remiss in leaving this out, because this is really sort of key to moving us forward towards some of the other strategies that we are hoping to implement or to emphasize with states and with local jurisdictions regarding COVID-19 and beyond. The last comment I would like to make here is that ensuring public health reporting, no one likes to do reports, but electronic public health reporting really is going to be the key to ensuring that these tests, that they're useful and that they inform us providers, public health practitioners, and others who are responding to this emergency, that we are able to do what we need to do to flatten the curve, eliminate the expansion of cases. I would also just refer you all to the National Governors Association, which is a link at the bottom of this particular slide that you'll receive. This is a really good roadmap, I would say, to recovery that focuses a lot on telehealth, which we're talking about here today, but some of the other immediate needs that maybe if they're not a direct tie-in, they may have some levity on what our aims are in the public health and the health IT arena. So let's go to the next slide. So we talked about, obviously, there's the issue of testing. So in tandem with testing, contact tracing and surveillance is another really big topic that we are emphasizing as in terms of immediate, short-term, right now actions. And what we are emphasizing for states is that states really focus on strengthening their public health and their health data infrastructure, and that they use some of the relief funding to prioritize syndromic surveillance, emergency response, using even environmental data, clinical care document. I think the list goes on, ... And part of that has to do, what we're saying is really emphasizing syndromic surveillance, and that would include any sort of admission, discharge, transfer, or ADT notifications from hospitals. This is really important because it helps develop situational awareness for COVID-19, and that's really key. I think all of the points here really lead up to really improving situational awareness and the ability to respond to hotspots, to really focus resources where it's needed. Part of that is also considering the use of smart health technologies such as AI and machine learning to help provide predictive analytics. So once you have some of the surveillance data coming in, what to do with it, making the best use of that. And I would also emphasize that states should take a real active or focus on the growing availability of mobile phones and internet-based reporting tools to support contact tracing, outbreak, and any sort of diagnostic reporting. And in that, I think this is really important for those of us who are futuristic and we talk about smart healthcare, where surveillance systems are outdated. These are sort of the considerations that we're asking states to really prioritize, create a HIMSS chapter think tank in California to help realize some of these solutions. Next slide. This is just an example that was taken from the New York Times that looks at how some of our state and local governments had already started to track cell phone data. And it's just an example of things are already happening. The train has left the station, but it certainly gives bear to a lot of considerations, particularly privacy and concerns. And if we go to the next slide, we'll see that a lot of the surveillance has been used right now by health officials, governors, to inform some of their policy making. And the last slide, you saw just the number of people that within a certain period of time had reduced their the circumference of their activity. So they're going outside of the home, like how far they were going, and we saw that sort of reduced. And this particular slide really sort of emphasizes another aspect of what can be captured through surveillance measures, and it looks at hospitalization, the number of beds that are available, looks at hotspots where there are outbreaks. So again, I use this slide as a demonstration that there is definitely a need for additional models like this that not only inform the work that we do, but also policymakers and the decisions that they make about reopening society, which you hear a lot in the news right now. It's really important and vital for socioeconomic benefits that also are health benefits when we look at it. So next slide. This is a particular slide, I think, that sort of sets the stage for the next few slides. And what it is just emphasizing where there are gaps. And a lot of it has to do with, again, like surveillance, how and why, where we're capturing data, and if we're sharing data. The limited public reporting on race and ethnicity data is one that was highlighted quite a bit and is critical to helping us address gaps, particularly to the most vulnerable communities. That's really key. I would also say that the lack of interoperability, multiple spreadsheets and tools, so having to leverage that information, and we sort of talked about tools for decision making is really important, and to strengthen the public health informatics infrastructure. Again, if we go to the next slide, and the next slide, that's what we're really emphasizing if we go to the next slide. So we are also asking that states really consider mandating by either public statute or regulation, routine public health data submission inquiry. Basically, we're advocating for electronic case reporting in it as much as possible. And there are some resources now. The CDC recently has an electronic case reporting app that's being provided, that's being rolled out, I believe, as of this week or late last week, and we can certainly share the links to that. There's the digital bridge, and there are a number of other mechanisms that can be leveraged. Some of this I've also emphasized, I think, earlier, so we can go to the next slide. This is just an example of, you may have seen this already. It's a public-private community-based application between Epic and OCHIN and the Washington State Healthcare Authority that is really sort of helping, as you can see on the right-hand side or your left-hand side, the preparedness, addressing some of the infrastructure needs to underserved communities, but also providers who are working in the field or in underserved areas. There's a public health coordination component, the MyChart component, which is very nifty. It is allowing patients to actually sign up and start a personal health record. And the Care Everywhere component of this is that it integrates with electronic health records. And so I would just emphasize this is a great example or model of sort of where we're taking this. Next slide. I would leave you with the points around leveraging our health information exchanges. In terms of short-term, right now, what we can do, we're really emphasizing leveraging health information exchanges or any sort of cross-sector health data sharing platforms that are in your state to help collect some of the data across sectors that will be super informative to COVID-19 response and broader future needs in health. And states right now do have the authority to declare and deputize an HIE to collect coronavirus information. And there are some states that have already started to engage. And local and state epidemiologists, they're working with epidemiologists to create those dashboards that are insightful in terms of creating disease prevention maps. You've probably seen some of that on the West Coast and Washington State. They're doing a really good job with that. Also, Indiana is another. And I would just also say where there's a lack of capacity, they're not data analysts and they're not that many epidemiologists. HIEs actually could potentially, where there's the capacity, serve to support the workforce needs, the care coordination component, and helping to identify some of the social determinants of health issues. If we go to the next slide, I think that really sort of sums up a last example for you there in California, like the Sac Valley MedShares, the HIE in Northern Cal, that I think is starting to do a lot of the data analytics work supporting local communities. This is a wonderful example, and I think a great transition point in terms of you're doing a lot already in California. If we go to I think if we skip forward, I would just leave you with that. What I see sort of reflected in terms of, if we keep going, sort of reflected in your three asks, looking at obviously telehealth and some of the other aspects of what needs to be done right now. You're certainly on your way. And if we just skip ahead maybe to my last slide, which is maybe 3 more. And you'll all, by the way, you all will have access to these slide decks, I assume. Again, California scales the high bar, and I think certainly reflects where we need to go future forward. Happy to answer any questions afterwards. So with that, now I'd like to just introduce Jeff Coughlin, and he is our Senior Director for both for helping us in state, federal, and global affairs. And so Jeff, take it away.
Thanks, Valerie. Thanks everyone for joining the call today. I think you got a really good sense of all the activities that HIMSS has underway related to addressing the COVID-19 crisis and some of the actions that you can take at the state level in California. So I'm glad that we had the chance to have this discussion today. Just to take a step back in terms of other activities that are happening at the federal level, we are in the midst of trying to implement the final interoperability regulations from the Office of the National Coordinator for Health IT, as well as the Centers for Medicare and Medicaid Services. So I'm just going to take the next few minutes and try to run through some of the high-level points from those final rules, and then point you to some resources that are on the HIMSS website where you can get more details and more information. So in terms of the purpose of the interoperability regulations, and it's not news to anyone in California about the opportunities that exist around innovating in kind of the interoperability space and reducing the burden that's placed on clinicians across the board in terms of time spent on trying to get records from other entities and share their information with other entities. But I think the biggest thing around the interoperability regulations is really just promoting patient access. It's something that both ONC and CMS have really emphasized in terms of trying to empower patients, provide them more access to their information, and provide more control so they can share that information with whomever they want. They're really in the driver's seat. They're the quarterbacks going forward in terms of sharing their information. So on the next slide, it just provides a little some details on what's included in the CMS regulation. I'll just point out a couple key things from this slide in terms of the patient access API. So right now, underneath this final rule is that payers have to share claims information and other health information with patients in a secure, understandable, user-friendly electronic format. That includes adjudicated claims, their encounters with capitated providers, clinical data, and lab results. Some of the other, I think, big things from the CMS regulation really was the idea of payer-to-payer data exchange. So patients can direct a former health insurer that they use that they have to help coordinate their care by sending their health information to their current payer. That can be up to 5 years after their coverage ends with that former payer, but that's important in terms of continuity of care and making sure that information is available. The other, I think, big thing is CMS is using some of its other tools as part of the payment system to try to make sure that providers are abiding by the spirit and the rules around these interoperability rules. So those providers that are not positively attesting to the fact that they are not information blockers will be noted on a couple different means through the Centers for Medicare and Medicaid Services that are noted there on the slide. On the next slide, to talk a little bit about what's in the ONC regulation. So there are certification program related changes. The term that I think is really important is around the U.S. Core Data for Interoperability standard. So this is a new standard that has been adopted in the ONC rule, and it also applies to what's included to parts in the CMS final regulation. What was included as a part of the Common Clinical Data Set, the CCDS, is now really wrapped up and really increased as a part of this USCDI standard. So this is the new standard going forward. There's also specific API conditions of certification that are included that talk about trying to minimize the special effort that is often necessary to try to access, exchange, and use EHI. And EHI is referred to as electronic health information. On the next slide, really the big key takeaway from the ONC rule has to do with the exceptions for information blocking. So the default in the ONC rule is that information should be shared broadly across the entire healthcare ecosystem between providers, payers, as well, health information exchanges, developers, et cetera. But there are those instances when it would be acceptable to not broadly share that information. So this is where the 8 exceptions really come into play. So folks that read the proposed rule that was published last year in 2019 will remember that there were 7 exceptions. What's included in the final rule here was really not making too many changes to what was included in the proposed rule for those 7 exceptions, but really trying to draw out the specifics around this, the exception that was included there at the bottom, the content and manner exception. So that talks about the requirements around what an actor or a regulated actor in health information exchange is required to share, and then also in terms of the manner that they share it. So next slide, really quickly, I just wanted to run through some of the most recent changes. One thing that I didn't really mention was around what we're talking about for implementation timeframes for both of these rules. Not to get too much into the inside baseball here in Washington, D.C. with the federal rulemaking process, but these rules were released on March 9th, which would have been the first day of the HIMSS 20 Global Conference in Orlando. But ONC went ahead and CMS went ahead also in releasing their rules on that date, but they weren't published in the Federal Register until this past Friday. So what that means is that the actual clock in terms of implementation was not started until really this Friday. Obviously, there are mitigating circumstances in trying to address the COVID crisis, et cetera. So what ONC and CMS did was try to provide a little more enforcement discretion in terms of when enforcement around these rules is really going to come into play. So you can see here that CMS has announced several places where they are not going to extend the period when they're going to enforce the regulations around that they put together around interoperability. And ONC has also basically added 3 months onto the end of what would have been the enforcement period around their particular provisions in their rule. On the next slide, what was also announced on the same day as this enforcement discretion was the last piece really in the interoperability rulemaking process for the time being. And that's around what sort of penalties those folks that are deemed information blockers will actually have to undertake. So there really are 4 kind of regulated actors that were included under information blocking. Those are the health IT developers, the health information network, and the health information exchanges, as well as the providers. So developers, health information network, and health information exchanges are all covered by what's included in this information blocking civil money penalties proposed regulation. And they can be subject up to a $1 million fine per violation for violating the terms of the rules that we just discussed from ONC. Providers, on the other hand, are not covered by this $1 million fine, and providers would be referred to a particular agency, likely CMS, for appropriate disincentives that could come into play related to if they are deemed an information blocker. One more thing that I'll just point out really quickly, I know we're almost at time, is the fact that the HHS Office of Inspector General did say that they are going to use their discretion how they're going to impose these fines and investigate causes and cases of information blocking. So they have decided that they're really going to focus on certain priorities when it comes to information blocking. And those really, the causes really center around patient harm. When a patient has been harmed, that is when the information blocking penalties will really come into play. They also announced in this rule was that they're not going to really bring enforcement actions for innocent mistakes, for those folks that did not have an intent behind their information blocking. So I think that that's a positive sign in terms of those folks that are have a lot of different pressures coming at them related to COVID and other other things from the healthcare system that they do have a little time to try to figure out how to appropriately implement these information blocking rules. So I'll stop there. I know we're almost at time, and I see we have several questions. So I will just refer you to this last slide that has all of the resources on our page here. So Jenny, I don't know if I know Alana has been going through and answering some of the questions here in the slides. Alana, was there anything that you wanted to go back and answer related to some of the asks from the campaign that we have going related to the California chapters?
Giving them 1 second. I'm going to wait for them to get loaded.
So Jenny, do you want me to just try to answer a couple of the questions?